Hello, everyone, and welcome to this session on infant feeding and allergy prevention. I'm absolutely delighted to introduce a very dear colleague, Dr. Helen Brough, who is consultant in paediatric allergy at the Evelina Children's Hospital at Guy's and St Thomas's Foundation Trust. Dr. Helen Brough is very, very experienced in allergy prevention and extremely knowledgeable, and I can't think of anyone better to share this presentation with. I'm Karen Wright, and I'm one of the Senior Clinical Teaching Fellows on the MSc Allergy and also a paediatric allergy dietitian. So let's have a look at what your learning outcomes are today. So by the end of this session, you will be able to recognise the theory behind infant feeding and allergy prevention. You will also be able to summarise the current research in this field. And then you'll be able to discuss the current infant feeding recommendations. So we've got a lot to cover. However, before we get started, I want you to have a think about your level of confidence in discussing when to introduce the common allergens for allergy prevention with parents. So how do you feel about it? It's an area where there is always lots of new information coming up. So we hope that by the end of the session, your confidence level will have increased. Okay, so we're going to start with the theory behind infant feeding and allergy prevention. And I'm going to hand over now to Dr. Helen Brough. Thank you, Helen.
Thank you so much, Karen, and I'm delighted to be here to share this presentation with you and to highlight the very exciting recent research findings in this field. And this area is a rapidly developing area which is already translated into clinical guidelines and is making big impacts around the world. So I'm going to talk about the theory, and I'm going to first talk about breastfeeding and allergy prevention. So overall, what I would say is that the data is mixed. We know that breastfeeding is so important for the baby and for the mother for many, many different reasons: for maternal bonding, for diabetes, for prevention of obesity, or many other factors. But actually for food allergy, their evidence is not for or against. It does not say that it prevents or increases the risk of food allergy. And the reason for this is that it is actually difficult to do these types of studies with breastfeeding because they are observational and they have very different studies in terms of duration, variable criteria for food allergy. And then the other main thing is that we can't really do randomized controlled trials because it would be unethical to randomize mothers to non-breastfeeding. The other point to consider is that breast milk is different between different mothers, and that is very difficult to factor into any study. So I'm going to talk through some of the data where there is much more evidence. So oral tolerance induction started out with this very landmark study, the LEAP study, which I'm sure you have all heard of. Now, this was the Quad AI where it was presented. This is now some time ago, and then was published in 2015. And you can see here the image of a baby with eczema, red, inflamed, angry skin, who is surrounded by environmental exposure to peanuts. And we know that this increases the risk of developing peanut allergy through having a disrupted, inflamed skin barrier and having peanut in your environment if you're not eating it. What the LEAP study showed is that in children that ate peanut from early in infancy, that they were able to prevent peanut allergy very significantly. This is the study design for the LEAP study. So you can see here that children were recruited from 4 to 11 months of age, and they were either asked to avoid eating peanuts until they were 5 years of age, which was very much similar to the advice at the time, which was that children with a parental atopy avoided peanut for the first 3 years of life. So that was the control arm. And then the intervention arm was consuming high doses of peanut protein every week until they reached 60 months of age. And at that point, they have a food challenge to peanut, and they showed that there was a highly significant reduction in peanut allergy with an 81% relative reduction in the intention to treat arm. So the avoidance group had a peanut allergy rate of 17%, and the consumption group had only 3%. Now, what I want to mention is that this was 640 children that were at high risk of peanut allergy, severe eczema, or egg allergy. So the overall study findings were not just about preventing peanut allergy, but also about making sure that this was a safe intervention to do, that it was not going to do any harm for nutrition, that it was not going to make the children overweight. And so this was a lovely study that looked at all of these different aspects. The feasibility was strong, there were no choking episodes. And then in terms of the nutrition, they showed that breastfeeding duration was equivalent between the two groups, and that actually eating peanut was healthy, and that it often replaced other snacks that were less healthy, and that there was no increase in body mass index or waist circumference or other markers of obesity, even in those that ate the highest amount of peanut. So these are the conclusions. Early introduction of peanuts from 4 to 11 months significantly reduced the risk of peanut allergy. These were high-risk children for allergy. And what was wonderful about the LEAP study is that they did an additional LEAP-ON study where they looked at the children that had reached the 60-month end of the study, and then asked all children to avoid peanut for 12 months to see if the protective effect was sustained. And they found that it was sustained, which is great. Moving on to then the next study, which is the EAT study. So this was an important study because this was a general population study, and the LEAP study was a high-risk study. This was a very ambitious study in that they recruited 1,303 exclusively breastfed infants, and they randomized the children at 3 months of age to either continuing breastfeeding whilst introducing early solids and milk, egg, fish, sesame, peanut, and wheat from 3 months of age, or continuing to exclusively breastfeed until around 6 months of age, which is still the Department of Health guidelines. They assessed food allergy by 3 years of age, and these are the results. So you can see here that there is an intention to treat analysis and a per protocol analysis. And this is very important because you can see quite a significant difference in the results, because this study was actually quite difficult for parents to implement, particularly at this young age where they were asked to introduce multiple foods. And we'll talk about that in a few minutes. But essentially, in the intention to treat arm, there was a trend towards reduction in food allergy in the group that introduced peanut, egg, and the other foods early. And this is shown here for peanut, 2.5% down to 1.2%. However, in the per protocol group, you can see that actually the effect was very substantial, and it went down from 2.5% for peanut to completely zero. So there was 100% reduction in peanut allergy in the early introduction group. And this was the same in the adjusted analysis. So similar findings were found for egg, but actually for egg, there was a 75% reduction in egg allergy in the early introduction group in the per protocol arm. Because there were not that many children with milk, sesame, fish, or wheat allergy, I'm now showing you the data for skin prick test sensitization, because it shows that there were also positive effects of early introduction of the food for milk, which was statistically significant in terms of sensitization, for sesame, and there was a trend for fish and wheat. So the summary of the EAT study was that in this general population, there was still a benefit of early introduction of the 6 foods. And what was interesting was that it was in some ways a tricky study because many families were unable to achieve the amount of food that had been recommended, which was 4 grams per week for at least 5 weeks, between 4 to 6 months of the 6 foods. But because of that, they had a sliding scale of adherence to the study intervention, and they were able to look at what is effective. What is the minimum amount of food protein that is required to prevent food allergy and prevent food sensitization? And they found that 3 grams of the food protein was significantly associated with a reduction in food sensitization, and 2 grams was associated with a reduction in food allergy. Also, they showed that there was no impact of the intervention on the growth, on feeding difficulties, or reduction in breastfeeding or macronutrient status. And then there was one other study which looked at the effect of this intervention in children that were already at increased risk for developing food allergy by already having positive IgE on their blood tests. And they showed that even in the intention to treat analysis, that this intervention was effective in the higher risk group. So this is the PreventEdAL study, which was published in 2020 and also 2022, where they looked at a very large population in Scandinavia. This was 2,700 children from the general population. And this was a 4-arm study because they looked at both preventative emollient therapy, which was applying moisturizers and bath oils from early on, and early food introduction, which was different in this study because it was only very small amounts with what they called tasters, where the mum or dad would just put a tiny bit of the food onto their finger and then they would allow the child to taste it. This was between 12 and 16 weeks of age, and they used peanut, milk, wheat, and egg. Then there was a 3rd arm where they combined both of these interventions, and then a control arm, which was standard of care. You can see here that in the PreventEdAL study, there was a significant reduction in food allergy. There were 13 children in the intervention arm that developed food allergy, and in the control arm, there were 31. This was primarily driven by peanut. You can see here that in the intervention arm, there were only 9 versus in the control arm, there were 23. So this was highly statistically significant for peanut, but less significant for egg and milk. And obviously there was no wheat allergy. Again, you can see here that adherence was a problem because when you looked at food allergy in the per protocol group, there was an even higher reduction in food allergy. Finally, I'm going to talk about the SPADE study. And this was a really interesting study that was done in Japan, where they enrolled infants within 5 days of birth. And these were infants that were breastfed and had already potentially had cow's milk formula. They were randomized between 1 and 3 months of age, either to have some breast milk plus cow's milk formula of 10 mils or more per day, or to have breast milk plus or minus soy formula. And then after that, they were allowed to continue on breast milk plus or minus cow's milk formula from 3 to 6 months of age. And at 6 months of age, they had an oral food challenge to cow's milk formula at 100 mils. And you can see here a substantial reduction in cow's milk allergy at 6 months of age in the group that were eating cow's milk allergy at least 10 mils per day between 1 and 3 months of age. So all of these studies were included in the European Academy Food Allergy Prevention Guidelines, which I am showing you here. So breastfeeding and pregnancy, there was no need to restrict food allergens during pregnancy or breastfeeding, but they did recommend against using soy formula. There were no recommendations made for or against breastfeeding, or for or against cow's milk formula or hydrolyzed formula. And there were no recommendations for or against the use of vitamins, minerals, prebiotics, probiotics, symbiotics, or omega-3 fatty acid supplementation due to the mixed evidence for this. However, there were recommendations for introducing age-appropriate peanut-containing foods in countries with high prevalence and well-cooked egg as part of complementary feeding. There was recommendation against supplementing with cow's milk formula in breastfed infants in the first week of life, or using soy formula for prevention. and there was no recommendation for or against the use of vitamins, minerals, prebiotics, probiotics, symbiotics, or omega-3 fatty acid supplementation during infancy. So now I'm going to talk about some of the limitations of early introduction of solids and limitations of oral tolerance induction. This is a very recently published study, which was long awaited because it combined all the data from the LEAP study, from the EAT study, which I've already discussed, and also the PARS study. Now, the PARS study was a study that looked at the children that were screened for the LEAP study, but were not included. So these were children that had eczema that was too mild to be included into the LEAP study, which was the low risk in green that you see here. And then these were also children that were already deemed to be allergic to peanut because they had a skin prick test of more than 4 millimeters to peanut when they were screened. So this is in red, the very high risk group. They were able to combine all of these three populations, so including those that were included in the LEAP study and all the children from the EAT study, into an analysis sample. What they showed, which was very interesting, was that actually if you just target the most high-risk children and introduce the peanut introduction early on, at a population level, actually, that doesn't make a huge impact on the reduction of peanut allergy in the population, because most children who develop peanut allergy will actually be in the low-risk group because there's so many more of them. So that was the first message from this study. In the bottom half of this graph, I'm going to talk about the window of opportunity. You can see here in the triangle, green and red, that the eczema duration in months and the age of the infant in months are directly related to how likely it is that that child will develop peanut allergy. The reason for this is that the longer you have eczema, the more time you have for peanut to get through the skin, through that inflamed, disrupted skin barrier. What they found was when they looked at the efficacy of prevention of peanut allergy through introducing peanut into the diet, that if you left it for too long, so you can see here the age in months on the x-axis, that the longer the child was left without introducing peanut into the diet, the less likely that prevention was going to be effective. So you can see here, for example, in the green, this was the low risk group versus blue medium risk versus purple high risk, or red very high risk. Even in the very high risk group, if you started at 3 months of age, there was a 60% chance that you would be able to prevent peanut allergy. And in the low risk, there was an over 80% chance. Once you got down to 12 months, these chances of being successful for peanut allergy were low. So 20% only in the very high risk group and only around 40% in the low risk group. So this shows that there is a window of opportunity and it is important to introduce peanut as early as possible, obviously safely, and when the child is ready to introduce solids. The next limiting factor for oral tolerance induction is that it is allergen specific. So this was data from the LEAP study, where you can see here at 60 and at 72 months that introducing peanut was very beneficial for the prevention of peanut allergy. However, unfortunately, it did not help with asthma, seasonal rhinitis, eczema, perennial rhinitis, or any of the other food allergies that were assessed by sensitization. That includes tree nuts, sesame, cow's milk, and egg. The next point on limitations is the adherence. And I had mentioned already that in the EAT study that the adherence to the recommendation for introduction of those 6 allergenic foods was very low. So only 42% of the children were able to adhere to the recommended doses for the study, which meant that 58% were not able to adhere to this. Now, they looked at the reasons why this might be. So certain enrollment factors, such as older maternal age, non-white ethnicity, and a lower maternal quality of life. And then there were post-enrollment factors, such as parents reporting that their child had had an allergic reaction to those foods, or if they had feeding difficulties, which is very important. But unrelated to adherence was the eczema at enrollment or sensitization at enrollment. So my take-home messages are, there is now a lot of data, and these are just some of the studies, the LEAP, EAT, and Prevent, Adele, and SPADE studies, but there are many others that have changed the landscape for the prevention of food allergy. It's hard to imagine that back until 2009, the recommendations were to avoid allergenic foods, in particular peanut, in the first 3 years of life. Now things have completely gone the other way, where it is recommended for early introduction of allergenic foods, particularly for peanut and egg. But there is evidence that also shows that it works for other foods, such as milk or wheat or sesame. The limitations of oral tolerance induction are plentiful. There is a narrow window of opportunity. So when you meet a child, if they're already 11 months of age, it is going to be less effective, your introduction of peanut or other foods. The child might already be allergic to those foods if they have eczema. And the other part which is difficult to address is the limitation of allergen specificity. It would be wonderful if peanut introduction could prevent tree nut allergy, but unfortunately that is not the case. So that means that for each allergen, you need to introduce that food into the child's diet. And we already know from the EAT study that doing 6 foods was very, very difficult, and only 42% adherence was achieved. So we need something that will help children to be able to introduce the foods over a longer period of time. And there's quite a lot of work now being done to manage eczema, to try and give a larger window of opportunity for oral tolerance induction. In terms of feasibility to introduce these allergens, there are multiple factors to consider, and I know that Karen will be going through a lot of these factors in the next part of the presentation, and so I am delighted now to hand over to Karen to continue this presentation. Thank you.
Thank you, Helen. Thank you so much. That was such a valuable background and really sets the scene now for me to move on and give the history to some of the guidelines and perhaps understand why there is quite a deal of confusion amongst parents and healthcare professionals, and then look at the more practical aspects of really applying this with our patients in practice. So I think, first of all, it's really important to talk about terminology, because weaning means different things to different people. And what I'm really going to be talking about is complementary feeding. So that's when we are introducing solid foods when breast milk or infant formula is no longer sufficient to meet the nutritional requirements of an infant's rapid growth. So the infant feeding guidelines are really talking about this, the introduction of solids. And you can see through this timeline that I've put together that before the 2000s, prevention strategies really focused on avoidance of allergens in both the maternal and the infant's diet during the first year. And in fact, peanuts were advised to be avoided until at least 3 years of age. And so avoidance of all of these allergens in infancy became widespread. Between about 2000 and 2010, and interestingly, 2010 was the last UK infant feeding survey. So that's the last data that we have on when different foods were really introduced by the population. We saw a significant move towards longer periods of exclusive breastfeeding and the later introduction of solids. And that also meant that allergens were introduced later as well. So actually, all of the guidelines were very successful up to this point. But allergy prevalence didn't decrease, and in fact, they increased. And what's really interesting is some of the data from that survey in 2010 showed that around 45% of mothers of 8 to 10-month-old infants avoided giving one or more of the allergenic foods. And around 41% avoided giving their infant tree nuts, and 92% avoided giving them peanuts. And the main reason for delaying the introduction of these foods was fear of an allergic reaction. And that really was on the back of the way that the guidance was promoted to parents. So by 2008, this advice started to change because there was increasing evidence that delaying the introduction of allergenic foods was associated with an increased risk of allergy. And at around 2015, where we had the publication of the LEAP study, there was a real shift in infant feeding advice, and we were moving away from the delayed introduction to the deliberate introduction of common allergenic foods. So you can see this big change, and it's really hardly surprising that not only are healthcare professionals sometimes a little bit confused, but that parents are also really confused about what they should be doing. We still have the WHO advice to introduce solids at around about 6 months and to continue breastfeeding up until around 2 years of age. But this advice, and all of the advice from different countries around the world really reflects different national population health priorities, with lower income countries prioritizing the need to prevent infant and reduce infant mortality, infection and malnutrition, whereas in the higher income countries, infant feeding guidelines really target the prevention of non-communicable diseases, including food allergy, which represents a growing public health burden. So this little graph here really demonstrates that shift in the introduction of solids. So with the light blue boxes on the far right of each group there, you can see that by 2010, many more parents were introducing solids after 4 months than before 4 months. There are many other factors that are also involved in the timing of solids and timing of introduction of solids, and they include gastrointestinal, renal and immune development, developmental readiness, which is so important for the introduction of solids, nutritional adequacy, social, cultural and parental preferences, but also taste and texture preferences in the infant, as well as family and infant history of allergic diseases. Most infants don't require complementary foods before 6 months in terms of nutrition, but obviously for allergy prevention, we're looking at a completely different reason there. Many individuals may benefit from the introduction of complementary foods before 6 months. For example, those where there is a risk of iron depletion, and certainly for those to prevent allergy. So let's have a look at the current UK guidance, and then I'm going to have a look at some of the international guidance with you as well. So the current UK guidelines are that breast milk really is the best way of feeding a young infant and provides all of the nutrients a baby needs until around about 6 months. That families of infants with a history of early onset eczema or suspected food allergy may wish to seek medical advice. That's the wording in the current guidance. The current guidance also says to introduce the allergens from around 6 months of age, one at a time and in small amounts so that you can spot any reaction. And that delaying the introduction of peanut and hen's egg beyond 6 months may increase the risk of developing an allergy to these foods. They also state that once introduced and tolerated, the allergens should form part of an infant's usual diet. And if the initial exposure is not continued, it may increase the risk of subsequent food allergy or sensitization. So that's the wording of the current guidance. Now, in 2018, the British Society of Allergy and Clinical Immunology published their guidance, which really integrated with the Department of Health advice. And they published this, which is available on their website to both parents, and there's a specific guidance for healthcare professionals. I've put the information there at the bottom that you can go and have a look at this too. So you can see on the right-hand side, we've got the babies there with either low risk or no risk factors. And the advice there is to introduce solids at around, and the allergens at around about 6 months of age, but not before 4 months. And that peanut and egg and other allergenic foods that are eaten as part of the family's normal diet should be included. On the left-hand side, we've got the infants with a known risk factor for food allergy, which is eczema, particularly early onset, and existing food allergy in a baby already. So these babies should have the earlier introduction of egg and peanut alongside other solids when the baby is developmentally ready for the introduction of solids. So here in summary, for those children at lower risk or no risk at around about 6 months, and for those with slightly higher risk from 4 months when the baby is developmentally ready. As Helen has already described, because the efficacy of early introduction is time sensitive, it's so important that these discussions happen early. They need to happen before complementary feeding should begin. Because if you wait, then I think that creates quite a lot of anxiety for parents because they haven't had the opportunity to have these discussions. There hasn't been the opportunity for shared decisions, for parents to make informed choices and decisions. So incorporating the parental values and preferences along with the current scientific understanding is so important in making these shared decisions. This is also included in the BSACI guidance for healthcare professionals, and I think really nicely illustrates the number of children that will benefit from the early introduction of both egg and peanut. Remember that those infants with moderate to severe eczema are at greatest risk of reacting to egg and peanut when these are introduced into the diet, but they are also the ones that stand to benefit the most from the early introduction. And I think Helen has already gone through that in quite a lot of detail. But some babies will develop a food allergy despite following this prevention advice. And the guidance gives some very good and very helpful information on how to recognise and manage any allergic reaction. And I think if you're using these guidance documents with your families, it can really reassure them about what to do should a reaction occur. And in my experience, it's when you discuss all of these factors and a parent feels really confident about what they need to do that they will do it. So when we look at infant guidelines around the world, many of them have been revised to encourage and recommend the early introduction of peanut and egg and not to delay the introduction of other allergenic foods. However, there are inconsistencies with some of the guidelines recommending different approaches. So for example, in some countries, screening for sensitization prior to the introduction of foods is recommended and based on different risk scenarios for food allergy. In some countries, the advice is limited to particular allergens, or in others, a universal approach for the introduction of all allergenic foods and for all infants. In general, most of the guidance around the world recommends the introduction of solids at between 4 to 6 months, from 6 months, or at around 6 months, but not before 4 months. In 2016, the Australasian guidelines were updated to recommend that peanut and cooked egg and other common allergens should be introduced in the first year of life. And I'm going to talk about that a little bit later, and that follows on very nicely from some of the information that Helen gave, because we know that there's a very definite window of opportunity, and the longer we leave it, the increased likelihood of allergy developing, particularly in those children with eczema. In the US, their guidance initially was advising screening prior to introduction. Modelling in the Australasian population-based health nut study found that an early intervention strategy which targeted high-risk infants would require screening of about 16% of the population. And that would be challenging to achieve given limited access to testing in all geographic regions throughout Australia, but it would still miss about 23% of peanut allergy cases. And again, this concurs with what Helen was presenting earlier too. Interestingly, in some countries like Singapore, which is where I worked for a very long time, they did have a very low prevalence of peanut allergy, but in fact now that is actually their most prevalent form of allergy. It suggests that there is regional variations in drivers of food allergy, and therefore these may be warranted to sort of bring out in the different guidance documents. So these are the IACI food allergy prevention guidelines that Helen has already gone through, so I'm not going to go through those in any more detail. Studies that support the avoidance of cow's milk in the first week of life, which the IACI guidance were based on, Helen has already gone through some of these studies with you. So I'm, again, not going to go through these, but they're detailed here should you wish to find out more information. So diet diversity and allergy prevention is a very new area, and there have been quite a lot of papers published in recent years looking at these. There have been 2 IACI position papers as well on diet diversity and the role of dietary fibre. So let's have a look at these in a little bit more detail. This pasture study, which looked at parental allergenic history, found that increased exposure to an increased diversity of foods had significantly reduced the risk of asthma and also food allergy up to 6 years of age. Now, these were quite early studies, which were conducted in the early 2000s. Coming on to a much more recent study, which you will all know, Professor John Holloway was involved in this, and many of you will also know Karina Venter from around about this area. So these studies showed that for each additional food that was introduced by 6 months, the odds of developing food allergy over the first 10 years of a child's life was reduced by around about 10%. And similarly, for each additional allergenic food consumed by 1 year, there was a reduction by 33% in the likelihood of food allergy over the first 10 years. So what's really important is that when we're recommending early introduction, that we remember about all of the other foods that we want to be introduced into the infant diet as well. In terms of diet diversity and maternal diet, this is also proven to be very important. And we found that foods that should be increased to help prevent against the development of allergic disease are yogurt and vegetables, and foods that should be reduced include red meat, fried potatoes, fruit juices, cereals, and some refined grains. The IACI position paper on diet diversity is listed here, and this actually states that they recommend that infants of any risk category for allergic disease should have a diverse diet. There's no evidence of harm, and there are some potential associations of benefit in the prevention of particular allergic outcomes. In relation to dietary fibre, this is another paper that was very recently published. And in this review, it highlights the importance of dietary fibre as a dietary ingredient and its effect on the microbiome, its effects on immune regulation, and the importance of appropriate timing of introduction of these foods to target any potential window of opportunity and the potential mechanisms for dietary fibre in the prevention and management of allergic disease. A lot of research is still ongoing in this very complex and vast area, but I'd encourage you to have a look at this paper as well. Other strategies for the prevention of food allergy, Helen did go through this with you in the IACI guidance, so I'm just going to quickly move on and not really go through these in any great detail. There is quite a lot of study at the moment on vitamin D status as well, and the impact of vitamin D supplementation in the Vitality study, and this is going to be completed in several years' time. So let's have a look at the early introduction in practice. So we've spoken many times about readiness for solids and developmental readiness, and that's so important before you go ahead and start this. So what does developmental readiness mean? Well, it means that a baby should be able to sit up with support. Now, we're not expecting that they're going to sit up on their own. This is with support. So in a high chair where they're well supported, perhaps with rolled up towels or cushions behind them and either side of them, but more importantly, that they can hold their head steady. That they're able to remove foods from a spoon and swallow most of that food rather than spitting it right back out. So that's loss of the tongue thrust reflex, and that happens at around about 3 or 4 months. That they will open their mouth when they're offered food on a spoon, and perhaps also reaching out to grab food or a toy. So that shows good hand-eye-mouth coordination. When you're first introducing solids, it's very important that you don't just dive straight in and introduce the allergenic foods as the first food. Instead, you want to ensure that a baby is well established on a few first foods, such as vegetables or fruit. And this is so that it's because it can be difficult to distinguish between an inability to manage solid food, so perhaps that developmental readiness not quite being there, resulting in gagging, vomiting or coughing, as opposed to an allergic reaction. So really you want to establish that the baby is able to manage eating and pushing that food to the back of their mouth and swallowing before you start with the allergenic foods. And also, they actually provide a vehicle or another food to mix those allergens into. So I usually go through this with the parents, and this may take a week in some babies, it may take 2 in others. It really depends on the individual infant and where they are in their development. So how much food should be offered? Well, as Helen already discussed, it's about 2 grams of the allergenic protein. Now, that's what's really important. It's not 2 grams of the food, it's 2 grams of either peanut or egg protein we're looking at specifically here. And these, the reason that these are introduced first within the BSACI guidelines is because the evidence has been strongest for these foods. And these are the foods that have primarily been studied to date. So the 2 grams is based on the dose response data from the EAT study, showing that a mean weekly dosing of 2 grams of peanut or egg protein was highly protective against peanut or egg allergy. We don't really have efficacy data for lower doses at the moment, and the data for other allergens is yet to be established, but these volumes have shown not to negatively impact growth, micronutrient intake, or breastfeeding rates. So I think that's a very good basis on which we can use the introduction of other foods as well. So what does that look like in terms of egg? Well, it's about half a small egg, cooked well, so that would be hard boiled, and fed about twice a week. So we're looking at around about 1 egg over a week. And with peanut, that's a heaped teaspoon of peanut butter. Now, what's really important is that that peanut butter is diluted either with expressed breast milk or with formula milk if the baby is being formula fed, or with water. Now, warm water. If the baby is below 6 months, that warm water will need to have been previously boiled and cooled. And the reason that we dilute the peanut butter is it's quite thick, it can be quite claggy, and that represents a choking hazard. So here are my top tips for introducing the allergenic foods. So we generally recommend introducing them 1 at a time, and that's so that if a baby does have a reaction, it is easier to spot which food caused the problem. So in a meal, you would only want to introduce 1 new allergen. Always introduce when the baby is well, so when their eczema is well controlled and they are not unwell. And introduce early in the day. I usually recommend before 2 p.m. in order that there's time to monitor the baby over the afternoon, and also it all happens before bedtime, so that if there is any reaction, this can be managed throughout the day. I usually recommend to start small, so that might be in very anxious parents on the tip of a teaspoon or 1/8 of a teaspoon, building up to a 1/4 teaspoon, and then doubling the amount until an age-appropriate portion is reached. Now, that can happen in 1 meal, or for some families that may happen over several meals. But what you don't want to do is for that to take place over weeks, because then the introduction of these allergens is very, very slow, and we know that we've got that window of opportunity. Introducing small amounts means that if a baby does have a reaction, it's going to be to a very small amount of the food. Importantly, once the food has been successfully introduced, we need to continue giving that food as part of their regular diet. And we usually encourage this at least twice a week to prevent food allergy. If the baby doesn't seem interested, then try again on another day, and important to go at the baby's pace and include other foods at the same time. So we've got that diversity of foods being introduced into the baby's diet. So this is how I usually recommend the introduction of eggs, always using lion stamped eggs, introducing it initially in pureed egg, so the egg must be cooked, hard boiled and chopped, and then pureed, and that can be mixed with fruits or vegetables, yogurt or baby cereals. And then as the baby develops with their eating behaviors and managing other textures, it can be offered as scrambled egg, which is obviously less well cooked, but you would still need to make sure that there's no wet or runny bits through that scrambled egg. The hard boiled egg is what should be introduced first of all. And as I said, we're aiming for 1 egg over the week. So this is some pictures that I often give to my patients so that they can see how that can be introduced and prepared. And then for peanut, mixing that, thin it down with either some cooled boiled water or some formula, and giving 1 heaped teaspoon. So on the left-hand side, that's the measure of 1 heaped teaspoon, which has been diluted. And then this is it being fed on a weaning spoon, and that's approximately 2 weaning spoons. Other foods that parents may wish to introduce include the tree nuts, cow's milk, wheat, and then any of the seeds like sesame, fish, and seafood. So I've got some information on this slide here about how you can introduce those. And importantly, with the tree nuts again, we're never introducing whole nuts or coarsely chopped nuts to children under 5. So using the very finely ground or nut butters are a very good way, and mixing those with pureed fruits or vegetables. And then cow's milk can be introduced as yogurt or as fromage frais, or as fresh milk added to, for example, porridge or mashed potato. Wheat can be introduced as a cereal like Weetabix, or as couscous. That's a very good way of introducing wheat to little ones. For the seeds, for sesame, that can be introduced as a paste in tahini or crushed sesame seeds, or as hummus. But just bear in mind that the amount of sesame in hummus might be quite low. And then with fish and seafood, introducing that as pureed fish initially, or flaked fish, obviously very well cooked, and a variety of different fish as well. So that's your white fish as well as the oily fish. Okay. So Helen has already mentioned some of the challenges with early introduction, and we know that food refusal was one of those that was experienced in the EAT study, as well as the age of the mother, with older mothers tending to delay the introduction of the allergens, and those of non-white ethnicity also tending to delay the introduction. And what's very important is discussing culturally familiar foods with these families and giving really targeted support to these families so that they feel that they're able to do it within the culturally appropriate foods relevant to them. We know that children learn and their food behaviours are all learned by exposure. So fewer exposures will always be needed in younger infants, but as an infant ages, it's really important that they're offered these foods frequently, not only to maintain their tolerance, but also their acceptance of these foods. And we know that in older children as well, the less frequently they're offered a food, the less likely they are to want to eat it. So this covers all of those practical issues associated with the early introduction of solids. So what other considerations do we need to have? Well, some children will just not be ready at certain stages, and it's so important that you do discuss that with the parent, and that when a baby is developmentally ready, these foods are introduced, because it can impact on their acceptance as well if they are introduced to them when they're not ready. So going at the baby's pace is very important. There are some concerns that the early introduction can also over-medicalise the natural process of the introduction of solid foods, and that culturally or traditionally accepted practices may not be considered in the early introduction. So it's very important to consider the family that you have in front of you and what foods would be considered appropriate for them. It does increase pressure on parents, and I do see this with some parents getting so anxious that their baby has to eat the right amount of the food every time it's offered. So discussing those areas with the parent and talking about this in relation to ensuring that a good relationship with food is maintained and continued. I think that our own anxiety as healthcare professionals can also have an impact, and it's very important to recognise that. Parent or sibling food allergy will also have an impact on whether or not the allergens are introduced at all or early with the infants at higher risk of food allergy. And in the BSACI guidance, there's a lot of very good information on introducing the allergens where there is a sibling or a parent with food allergy. So I would encourage you to go and have a look at those. There is a bit of misinterpretation because some parents feel or think that the early exposure can happen through breast milk, but we know that it needs to really happen through the oral route. Concerns regarding eczema flares and that being due to allergen introduction can also prevent many of the parents continuing to introduce foods. And also a word about baby-led weaning. More food tends to go on the face and on the baby's body than goes in through the gut. So I always advise when introducing the allergens to spoon feed. In a baby who has eczema, I would also recommend using a barrier cream around the mouth so that the food doesn't have skin contact with the infant, which could cause a flare, which may be misinterpreted as a reaction as well. It's important to talk about when the family are going away on holiday, because this is when they tend to have gaps in their routine, and perhaps you may not get that food continue to be introduced at that time. Also, to consider the higher protein intake in early childhood and the effect on later obesity. So looking at the different foods which might be introduced there. Also want to just briefly mention on some of the commercially produced foods which are being promoted around the early introduction of these allergens. These are mainly available in the US. There was going to be one food which was going to be marketed in the UK, but that's actually now been withdrawn. And I think that they're looking at how that could be introduced within the UK market. Important factors to consider here is that many of these products do have very low protein contents, which doesn't really match what we're trying to achieve with the amounts of food proteins that we've already discussed today. And they certainly don't match the protein contents that have been used in the research that Helen mentioned earlier. Many of these products can contain numerous allergens in one food, so therefore it becomes difficult to spot which food caused a reaction if one should occur. And also think about the nutritional composition of these foods. They can be very expensive. So for example, one food that's available in the US, a sachet is £3.39. So it's certainly much cheaper to use the real food. And will encourage greater diversity of introduction of foods too. So some of these are available on Amazon. So you might find that some of your families do discuss these with you. They're not readily available and not available in the supermarkets at the current time. So in summary, in terms of complementary feeding and the early introduction of solids, the current guidance is introducing at around 6 months of age, but not before 4 months, to introduce vegetables, iron-rich proteins, fruits and cereals as part of those first food introductions. And then with the earlier introduction of the allergens to prevent allergy when the baby is ready from around 4 months, although research is showing that perhaps it should be even earlier than that, but really the developmental readiness is very important there. And then progressing on to more textured foods from around 6 months, including finger foods. Vitamin D supplementation, very important according to the local government guidelines, and avoiding sugar and salt. So is this allergy prevention advice working? This is a summary from a very nice recent paper, which showed that in Australia, the evidence demonstrates that there has been a high uptake of the guidelines, which recommends introducing the allergenic foods in the first year of life. However, it's not had the impact on food allergy prevention and prevalence that we'd expected. And perhaps that is much more associated with timing and also amount of food protein. So if you remember in Australia, the guidance says in the first 12 months of life. So perhaps introducing it much earlier than that is what we need to do. And there is more research going on. We know that there are barriers to the regular incorporation of allergenic foods into the infant diets, and these require further intervention and strategies and research. So there is still much to do. So just adding on to the take-home messages that Helen had given you earlier, really important to have increased diet diversity, to think about the impact of the early introduction of solids on breastfeeding. And thankfully, all of the studies to date have shown that it didn't have an impact. And I think that just thinking about the number of meals that you're asking a mother to introduce to a baby, if you're trying initially to do that early on in just one meal, you can certainly get the peanut and the egg in that, and then slowly introduce up to 2 and then 3 meals. And that really shouldn't impact breastfeeding at all. Think about the increased protein intake and the displacement of other foods, because the food diversity is so important. And remember that this can be challenging for parents. So I've included some other guidance documents here, which you can refer to. And here is some general information on the introduction of complementary foods, but also on allergies, introducing allergens to infants at higher risk. The preventallergies.org.au website is great. And there's another one called Nip Allergies in the Bub, which is also an excellent Australian guidance document. So hopefully you now feel a little bit more confident about discussing the introduction of the common allergens for allergy prevention with parents, but also discussing many of the food allergy prevention guidance and topics that we've discussed with you today. So I'm just going to close the slideshow now, and I'm going to ask Dr. Brough a few questions. So thank you, Helen, for your really, really great and very thorough discussion about all of the research. I've just got a couple of questions that I wondered if we could just talk about and really share with some of the students. So do you think that many of your patients are aware of the allergy prevention advice out there, and in particular, the importance of the earlier introduction of solids to those babies who are at higher risk of developing food allergy?
Well, I would say no is the sort of easy answer. I think that obviously I'm seeing a very specific group of patients. Most of the patients that I see do have eczema and do have some form of already having had an allergic reaction to a food. So I'm looking at a highly atopic population. Because mothers are advised in the UK to exclusively breastfeed until 6 months of age, often when I broach the topic of introducing solids earlier than 6 months, they're rather shocked and worried that the child is not developmentally ready yet. And so it's really important to validate the concerns that the parents have, and to talk about all of the ways to assess if the child is developmentally ready to take solids, and to provide them with enough information to be able to do that in a supported way. And that's why dietitians are so crucial as well for this, because they can provide the kind of support that is not feasible in a busy clinic.
I agree with you. I see many mums who think that there's suddenly overnight a magical switch that happens at 6 months, and then suddenly they're going to be ready. And, you know, I think many mums feel that their baby has to be able to sit on their own without support before they're developmentally ready. So just discussing that is really important. And then I think they understand that they can be introduced safely earlier. And I think that whole impact around breastfeeding is something that they have huge concerns about, and something that I spend quite a lot of time talking to them about, but also supporting them with as well. What do you think we could do better in terms of making the public and the general population more aware? Because as you highlighted, this isn't just relevant for those babies who are at higher risk. I mean, we could prevent a lot more allergy, couldn't we, by encouraging this practice in the general population too? And Helen, what do you think we could do better to inform more families and probably more healthcare professionals about the benefits that earlier introduction can provide in terms of allergy prevention? Because as you indicated and showed, the research is showing that this isn't really just for those high-risk infants.
Yes, I think that's a really good question. And I think that there are challenges around that, because the current Department of Health guidance is still stating that they recommend exclusive breastfeeding for around 6 months of age. So I think that in terms of having that reach, in terms of speaking to parents, GPs, health visitors, it's important for them to know that the data shows that introducing solids earlier than 6 months did not have an impact on breastfeeding duration. And so it is safe to do, and that the benefits of preventing food allergy are particularly in high-risk infants, but for the general population is also very strong. In terms of at least getting the children to start introducing these allergens from around 6 months of age, I think that is a message that is much more easy to make widespread. And that is also supported by the COT guidelines that have come out, not to prevent the introduction of allergens beyond 6 to 12 months. So I think that is an area where there could be some more national promotion, and that is something that I think it would be very helpful for the prevention of food allergy.
So it's passing on the knowledge that we all have and ensuring that that goes down to the midwives and the health visitors. And I think just giving this information to families earlier as well, I think that when it's given at the time that solids should be introduced, it can create quite a lot of panic, because I think parents don't get the opportunity to perhaps fully explore the rationale behind it, or be given the opportunity to discuss it with a healthcare professional. So I think bringing that much earlier in an infant's life is quite important. I think we've got lots to do. And I think Australia have actually really led the way in that they've got some really lovely information for families. I'd love to see that happening here as well. Do you find, Helen, that when you're asking parents to introduce the allergenic foods earlier, that many of them request testing? Is that something that you find is fairly common?
I would say that because they're in an allergy clinic, they obviously have access to testing. I think if I was in primary care, I may have a very different experience. I think a lot of it has to do with people's perception to risk and the knowledge that they have. And being able to tell families that are not at high risk of food allergy that it's important to get the food into the diet, and that their child is not at high risk of food allergy, and therefore they should just get these foods into the diet and don't need to have any screening. That's very important to get out. For the children that have severe eczema, I think it's quite controversial. Some people would suggest testing. Some people would suggest not testing, because it delays the introduction and potentially is more likely to lead to the food allergy occurring. I think that these situations, it's important that parents know that anaphylaxis in infants is very rare to the nut introductions, but it can happen. So they need to be made aware of how to manage and recognize allergic reactions. And then I do find, because I have the luxury of being able to do allergy testing in my clinic, that especially if it's negative, that's very beneficial for families. If it is positive, then obviously I will always do a blood test to confirm, and we'll try to put them forward for a food challenge. And if it's in the grey area, I think it's really important that we can offer supervised introductions of these foods. So screening can throw up a lot more in the way of complexities if you have grey area sort of test results. So in that situation, I think unless you have the capacity to actually be able to provide some form of supervised food introduction, then screening may be more harmful than beneficial.
Thank you, Helen. And then finally, which of the allergenic foods do you find creates the most anxiety for parents when they're asked to introduce these, particularly when they're asked to introduce them earlier than 6 months?
I think peanut probably is the one that causes the most anxiety, because of the reports in the press about people sadly having lost their life due to accidental peanut exposure. I think that egg and milk are less anxiety provoking, and tree nuts are probably also anxiety provoking.
Yeah, I agree. And I think also all of that information, and the guidance from many years ago has really held itself, has really stuck with people. And I think that grandparents remember that, and they create that fear in their child who's introducing peanut into their own infant. Yeah, I agree with you. I find the same. Well, thank you so much. It's been an absolute delight, and you've shared so much. You've shared your knowledge, your experience, all of your skills. It's really been excellent and absolutely invaluable. Thank you so much.
Thanks to you, Karen. I also loved your presentation. It was excellent.
Thank you.